sort of refashion this talk just a little bit to see if I can cover a couple of two very important challenging areas in terms of patients with locally advanced T3, T4 tumors, and then the idea that maybe treating the primary in the setting of, we'll say, oligo or minimal measurable metastatic disease, what the potential role for that will be down the run. So this is what I'm going to cover in the talk. So when we're talking about locally advanced disease, we're really going to focus on T3, T4. I'm not talking about fixed tumors where certainly surgery is not going to have a role in that, but resectable tumors. And then just looking at guideline risk stratification, focusing on high-risk disease. Indy's done a nice job of outlining that, and then very high-risk disease with large volume Gleason 4, Gleason 5. And I just reflecting on this a little bit, it's our cumulative experience with radical prostatectomy in optimal settings, and then expanding that to more locally advanced, potentially metastatic tumors, as long as we can minimize, to the extent that's possible, perioperative and long-term morbidity. I think in this setting, obviously, imaging is required. Sorry, let me go back. There's no controversy about that. A bone scan, CT scan we do, acknowledging the limitations in terms of sensitivity, particularly for small volume metastatic disease. I think I'm comfortable saying at this point that prior to going to surgery for a locally advanced tumor, I'm going to get an MRI on every single one of those patients so that I can have a very clear understanding of certainly the risk of extracapsular extension, adjacent structures. I'll take whatever information I can get in terms of lymph nodes, and I'm particularly interested in the geographic proximity of the tumor to the bladder neck, with the caveat that maybe I'm going to do a much more wide dissection of the bladder neck, potentially an en-bloc dissection of the bladder neck, in order to minimize the risk of a positive margin, and then the potential role for PET CT. This is just one example of a CT showing T3 disease here, right over here. And you can see the potential bulk of the tumor really extending posteriorly. And in this case, a corresponding FDG PET, high PSA, high risk, showing this tumor quite nicely. This is work that Eric Roran has done. Eric is our chief of radiology. He has a particular area of interest in PET for prostate, and this is just an example of how fluoride PET and these new imaging agents beginning to show us more about the potential extent of metastatic disease. In the context of oligometastatic disease, it can be quite critical because we may miscategorize a patient and therefore go down a path of potential local therapy when perhaps it's not appropriate. So I think one of the key challenges in doing radical prostatectomy in this setting is the risk with large bulky tumors, not just in the periphery of extracapsular extension, but also extending out to the apical urethra and obviously at the bladder neck. And this is something that Kevin Slaywin quite a long time ago introduced a modification of the radical prostatectomy of doing an en-bloc resection of the bladder neck in order to not separate that interface of the bladder neck with the seminal vesicles. So keeping all of that intact in order to get a negative margin, and I think that's a nice thing that I've incorporated, a number of us have incorporated into this. Other modifications, just from a technical standpoint, I think that it should be a matter of routine of keeping Denavier's fascia intact in general to minimize the risk of a posterior positive margin, but also in this particular setting of a bladder neck, a prostate base tumor, really kind of thinking about that en-bloc resection of the bladder neck. I think it's important to have some tool in our hand to identify the patient who's at higher risk for having occult lymph node metastasis, I think the standard of care, particularly in locally advanced tumors, would be to do not just a thorough bilateral true pelvic dissection, but there's some data I'll show you in just a minute to suggest that perhaps you should extend that proximal to the common iliac artery. This is a nomogram that Guy Godoy published in 2011. This is based on memorial data, and you can see that this AUC of 0.86, I've done a fair amount of work in nomograms in the setting of bladder cancer. That's significant. 0.86 is really good sensitivity for, in this case, the primary outcome measure, which was lymph node metastasis. You can see what a nomogram does is gives you some idea of the relative impact of a particular variable. The farther it is out to the right, the more impact it's having on the overall predictive model. And you can see the importance of PSA greater than 10, T2B or greater, biopsy Gleason score obviously contributing substantially. This is some very nice work that comes out of Bern, Switzerland. Studer did this in bladder cancer. This is a very similar study using intraoperative imaging techniques and injection of the primary organ, in this case the prostate, and showing the different levels of potential lymph nodes and therefore lymph node metastasis. And I think that Urs has done a very nice job, as well as others, of highlighting the importance of dissecting the internal iliac lymph nodes, as well as extending the dissection proximally. I think it's interesting, just reflecting a little bit on Indy's, just his last talk, Peter Scardino just always used to say, look, just do better surgery. Meaning, if you're going to do a node dissection, do a node dissection. I mean, I learned how to do node dissections when we were doing gold seed implantations. You know, the radiologist would come in, you've got the pelvis nicely dissected out, and as a third-year resident, I was learning how to do a proper pelvic node dissection, which is a complete clean out of the obturator fossa, you know, external iliac, internal iliac, and they were putting these needles into the prostate and putting gold seeds in there. But the beauty was we were taught how to do a proper node dissection. So it really is a complete clean out of the obturator fossa, which, in addition to the external and internal, which is the primary lymph node drainage. The incremental gain of going proximal to the common iliacs, I think, in my opinion, has not been completely codified when you do a thorough node dissection, but it's very clear that this should be part and parcel of any radical prostatectomy, assuming that we're doing radical prostatectomies on intermediate and high-risk disease, the patients who stand to benefit from it. The guidelines do address this, and this is just the EAU guidelines. And I think that certainly for high risk and intermediate risk, and I personally don't do radical prostatectomies on good risk patients, but that's, you know, I realize there's other points of view in that. So 53-year-old PSA of 4.7. Now remember that in patients with high-grade disease, PSA is not always going to be as elevated as you think it might be. He had an abnormal exam, 10 of 12 cores positive, all the way up to Gleason 8. And according to the nomogram, he had a risk of lymph node metastasis of between 16 and 30%. He had a negative cross-sectional imaging, and I offered him radical prostatectomy. Controversy as to whether you should do frozen sections if it's going to impact anything. My previous approach would be that if there was large volume nodal metastasis, I really was not convinced of the benefit of radical prostatectomy. I think today I really don't do frozen sections hardly in anybody, and I think a lot of people have just abandoned them completely, unless it's going to drive you in one direction or another intraoperatively. So anyway, so in this case he had bilateral frozen section positive and had the final pathology, locally advanced T3B, N2, Gleason 7, all the bad things that you can imagine, except I was able to get a negative surgical margin, which I was quite happy at least the initial results are quite good. We're gonna explore a little bit about a patient like this and the role of adjuvant radiation therapy in just a second, but I think that we would all be very happy with an undetectable PSA at this early juncture. So what about neoadjuvant therapy, for instance? So a lot of work has been done on neoadjuvant hormone therapy and then hormone plus chemotherapy. This is an old study from Southwest Oncology Group suggesting that There may have been a benefit to neoadjuvant hormone therapy in terms of, this is the PFS, overall survival. But then when you look at a meta-analysis, I think that the data is quite clear that while you can get better pathologic outcomes giving hormonal treatment ahead of time, I'm not aware of a study that's shown a long-term survival benefit. So I think that hormone therapy alone in locally advanced prior to radical prostatectomy doesn't have a place right now off clinical trial. I think I'd like to see the results of the PUNCH study, which was a randomization to hormones with or without docetaxel, plus radical prostatectomy. We'll see what that shows. But let's focus a little bit on adjuvant therapy, and specifically adjuvant radiation therapy. So I'll show you summary data from 3 large randomized trials showing a clear benefit to adjuvant radiotherapy. The evidence is compelling, and then I'll walk back from that just a little bit. So this is the SUA study, which was the eligibility requirements were a PSA of greater than 0.4 nanograms per mil. I realized that some of those patients have that's obviously, some of those are a detectable PSA, and you're sort of treating disease, treating occult disease, not just as strictly adjuvant. But you can see the profound benefit in terms of PSA relapse, defined by greater than 0.4, relapse-free survival, and there was also a benefit to metastasis-free survival long-term. And this, as well as 2 other trials, which I'm going to show you here, really cemented and provided high-level evidence supporting a role for adjuvant radiotherapy in the setting of high-risk disease at radical prostatectomy. Now, I kind of grew up in a salvage shop, all right? So what do I mean by that? So we were very early adopters of ultrasensitive PSA. Kevin Slavin had done a lot of work on this, and we brought it into the clinic very early on in the lifetime of ultrasensitive assays. So being aware of this data, we were in the habit of using the ultrasensitive PSA. So in the case that I just showed you, the patient has an undetectable PSA. I can't make them any better at that point in time. And ultrasensitive PSAs were not used in any of those 3 trials that I showed you. They used a standard assay. So as I mentioned, at least in the context of those clinical trials, some of those patients were actually being treated for occult disease, evidenced that they would have had a positive PSA on an ultrasensitive assay. But so then we say, well, okay, as soon as your PSA starts rising, we've got a bona fide rise, 3 PSAs separated by 6 to 8 weeks each, and a detectable PSA on an ultrasensitive assay, we'll treat you with radiation therapy. That would be salvage radiation therapy, not adjuvant. So here's some data comparing the 2, and this is not prospective randomized data, but the RAVES trial does address this in terms of salvage versus adjuvant. And I think the bottom line is that in a salvage radiotherapy setting, you can achieve, on average, this is 40% at 5 years, durable biochemical disease-free survival using an ultrasensitive assay in a salvage setting. But today, I can't tell you that one is better than the other. But that's generally been our approach to try to spare patients toxicity when they have a persistent, undetectable PSA. So what to do? Again, the compelling evidence is for radiation therapy. There may be a role for hormone therapy in that setting. This was ADT plus or minus mitoxantrone, and that trial was stopped early because some of the lymphoid cancers that were associated with mitoxantrone. But you can see that hormone therapy does provide long-term cancer control in this high-risk setting. Then the guidelines really provide options for all of those in the context of high-risk disease. So in summary, we've defined a set of patients who are high risk, T3, T4, high Gleason score, PSA greater than 20, and then this relatively small population of very high risk disease. And the truth is that radical prostatectomy can provide good local regional control, and it requires some modification of the surgery in certain circumstances. And then I think we have to adjudicate when we're going to offer radiation therapy in the setting of compelling high-level evidence versus salvage therapy? And is there a role in the patient who's going to get radiation therapy, for instance, for including hormone therapy with that, or doing hormones alone? Because you're going to have patients who have durable toxicity from the radical prostatectomy whom you're not going to want to offer radiation therapy. For instance, a patient with persistent urinary incontinence for one reason or another. Okay, so in the last part of this, I want to take advantage and talk a little bit about surgery in the setting of measurable metastatic disease. So now these are patients who have small volume documented lymph node metastasis or bone metastasis. I've taken the liberty of reaching out to Brian Chapin. Brian's a brilliant young urologic oncologist at MD Anderson. He's doing a lot of work, and I'm going to show you a trial that he's designed. And Daria Tilke from the Martini Clinic in Hamburg, who gave a very nice presentation recently at a meeting, so I kind of borrowed some of their stuff and some of my own. So there's retrospective data suggesting that there may be a benefit to treating the primary tumor. I think there's some potential obvious benefit in dealing with symptoms from locally advanced disease. One of the things that I learned in the radiotherapy era, which we at Baylor, under the leadership of Gene Carlton and then Peter Scardino, had a lot of experience in, is we dealt with the huge number of sort of just morbidity from locally advanced tumors. They obviously weren't resectable. And so there may be some potential benefit to that, but I think the primary thing is you remove the engine of metastasis by taking out the primary tumor, and I think that's the potential benefit. And by treating the primary, there may be an abscopal effect on metastatic disease. You see that with radiation therapy. So this is just sort of a high-level view of why treat the primary in the setting of metastatic disease. There's some population-based data that suggest that there might be a benefit. I'm generally a little bit of a naysayer about population data. I'm more of a clinical trialist in that respect, but in this setting where a very small number of patients, 3% had radical prostatectomy, about 2% had radiation therapy, there really did not necessarily appear to be a profound benefit, and at least the conclusion of this was that they did not advocate local therapy. So I think when you go into this, you have to have a healthy amount of skepticism, but keep your mind open to the potential benefit. Here's a paper that looked at more contemporary SEER data and drew an opposite conclusion. But look at the numbers, almost 14,000 patients, and roughly about 500 had so-called definitive local therapy. These are some of the details, and let me just show you the comparison was that radical prostatectomy was associated with, again, lower cancer-specific mortality compared to radiation, not a randomized trial, just observational data. And then another study that was just published in 2017, in this case a prospective case control study over about 15 years, small numbers, 83 patients, about a even split between radical prostatectomy and best systemic therapy, and with modest follow-up looking at a variety of survival outcomes. And you can see that this, in terms of castrate-resistant free and overall survival, very little difference, and the hazard rates for a variety of variables looking at predicting castration-resistant free prostate cancer, and you can see the numbers there. So some evidence for and against, and then studies that have looked at the potential impact and particularly quality of life outcomes looking at radical prostatectomy in highly selected patients. I think that we would take those numbers even in a non-metastatic setting. So remember, the principle is that we have to be able to perform this operation safely with good toxicity outcomes, and obviously we want to get a high probability of negative margins. This is what I mentioned before, that with more state-of-the-art functional imaging and PET CT, we may be underestimating, and what we're calling oligometastatic disease may actually not be oligometastatic. So there's 2 trials, fortunately, that are addressing this, and I just want to be very clear up front that we've had these discussions in our grand rounds. We had Brian Chapin come over and give an elegant talk, and I took the time to make a comment, because it's not just the academic people in the audience, it's our residents and fellows and private practicing physicians, that this is not something, in my opinion, that should be done off trial. This is something that is considered experimental and should really be done in expert hands with a lot of experience. Fortunately, we're going to have some clinical trial data in the future. This is a study that's being done across Germany, and this is a slide that Daria shared with me. It's the only slide I have about the study. Study's been a little slow to accrue. I think they've underperformed in terms of their projected accruals. You can see the eligibility requirements. They have to have a locally resectable tumor, T3 or less, good performance status, and their primary endpoint is looking at cancer-specific survival at 5 years. So I'm thrilled to be able to say that this trial just got approved in the US. This is a SWOG study. This is Brian Chapin's work. I'm not going to give you all the background. He's done a small multi-center phase 2 trial. So the idea is you take oligometastatic patients, best systemic therapy for 6 months. If they have a CR/PR stable disease and resectability of the primary tumor, then they can go into the second phase of the study and get either radical prostatectomy or radiation therapy. Some debate as to whether we're going to limit the radiation to 1/3 of the patients. It was originally designed as a surgical only a trial after best systemic therapy, but CTEP, the review committee at the NCI, really pushed back hard on that because of the lack of compelling data at the time that radical prostatectomy was somehow the only treatment that should be offered. Radiation therapy, as I've shown you a little bit, can also be effective. So this study will be activated, we hope, probably within about a 6 to 9 month period. It is a huge study. It's 1,200 patients. And this is going to require all hands on deck in the US and Canada to get this done. But it's really kind of our best foot forward with Brian's leadership and the SWOG leadership. It'll be done across all of the cooperative groups. So in summary, there's really no level 1 evidence to help us know what to do with the primary therapy, and what to do with the prostate in the setting of metastatic disease. The current data is low-level evidence, observational cohort studies, and as I mentioned, the radical prostatectomy should be done really in the context of clinical trials. And this is one clinical trial. You may have your own sort of institutional study looking at it, but I think it's really time that we start addressing the role of the primary in minimal oligometastatic disease. So thank you.